you. So, the best literature actually existing give you weak evidence in favor of bracing. Nevertheless, breast treatment is believed not to be able to produce AIS curvature. The most accepted criteria for AIS outcome evolution proposed by Scoliosis Research Society consider only avoiding progression, not reducing the curve. A consequence of this approach to AIS treatment is that above 45 degrees of poor attempt of breast treatment are generally considered at best an almost desperate attempt at waste of time. Reducing positive result in breast patients with idiopathic scoliosis above 45 degrees that refuse surgery have been presented in a retrospective study. Obviously, this can give only an efficacy analysis, since there is no control group, not it possible to know failure to the route. So the aim of this paper is to verify throughout a prospective control study in patients with idiopathic scoliosis above 45 degrees, still growing the final outcome. Our inclusion criteria is idiopathic scoliosis, at least one core of 45 or more, risk stage 0 or 4, age above 10 years, first evaluation in our institute from March 2003 to December 2010, and surgical intervention refused. As you can see, in our database is very rich, so among these, 85 patients respect the inclusion criteria, but 8 patients are excluded because they're still in treatment. So at the start, 5 years, 52.5 COP degree, research 41 accepted full-time race treatment to try avoiding surgery, and 18 surgery control. All patients in this group, in this breast group, were individually checked. We telephoned to patients dropped out from breast group and told that in the control group to verify if they had been finally fused, if they had not been operated, and we asked them to come to our institute with an X-ray for a free follow-up. Unfortunately, the patient number 1 rejected this offer since they did not want to know anything about their scoliosis. They were just waiting for progression symptoms to be operated. So each patient was including one of the following 6 subgroups: improved 5 degrees or more, unchanged, progressive 5 or more, unfused, waiting for fusion, not retrievable, and the last group included all patients that was not possible to reach to any reason. Since 2003 to 2004, patients who arrived in our institute have been treated with wrist cast followed by the life of wrist. From 2005, patients have been treated with the prospective wrist. At start, they were the wrist full-time for the first year, followed by 1 hour reduction for 6 months, and then a weaning of 2 hours every 6 months. Physiotherapeutic specific exercises have been prescribed systematically to all patients to be performed twice a week. We calculate the relative risk and the 95% interval of confidence of success, improvement of 5 degrees or more, and failure, no progression or fusion in 2 different ways: efficacy analysis and intent to treat. The efficacy analysis considered only patients who reached the end of treatment and were rejected for follow-up, and intent to treat included patients that come to first evaluation to our institute in the period considered. Result. The table describes the general result in the 2 groups considered. So, in the efficacy analysis, we considered as failure patients that progress, were fused, or are waiting for a future fusion. And in to treat, we have 5 failure in breast group and 10 in control group. And we observed that the control group had more probability of failure than the breast group. Considering the relative risk of improvement, the breast group had more probability of improvement than the control group. Patient achieved positive result, COP degree, ATR, and trace. This prospective control course study showed for the first time that the breast treatment can be useful for patients with good above 45 degree and still growing. The prospective design always does perform not only an efficacy but also an intent to treat analysis. The first one confirmed previous result coming from a retrospective study. Only the percentage of success reduced due to the inclusion of the dropout. The intent to treat analysis gives the real possibility of this treatment independently by the adherence to therapy. Factors that influence the result are the active height motivation, efficacy of race, and teamwork. A consequence, the possibility coming from this study is that the brace treatment for whoever above 45 degrees would not be considered as an alternative. In our perspective, bracing should be regarded as a first choice to try avoiding surgery. In fact, carefully considering sanitary and social cost of surgery, conservative alternatives should be regarded favorably. Throughout this study, we shall conclude that the conservative brace treatment is correctly performed and managed is a suitable alternative for the patients that reject any surgical intervention for idiopathic scoliosis at 45 degrees. Indeed, this treatment largely provides excellent results and in most cases stabilize the curve with a subsequent improvement of the curve degree entry score. Thank you for your attention.